Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 165 of our Pharmacotherapy MCQ series, which majors in infectious disease. And the first question reads, GTM, is a 45-year-old woman who comes to the clinic for a follow-up. She has a past medical history significant for HIV, which was diagnosed 60 days ago, controlled hypertension, and controlled asthma. Her current meds include elvitegravir boosted with cobicistat, tenofovir disoproxil fumarate co-formulated with emtricitabine, which she has been taking for the past 42 days. GTM had repeat laboratory testing 14 days ago. She reports good adherence and tolerability. According to her labs, her viral load is suppressed with good immunologic response. Compared with baseline, her chemistries show normal CBC and LFTs, but her serum creatinine has increased from 1.0 to 1.18 mg for DL. So my question to you is, which regimen modification listed below would be the best for GTM now? Would it be A. Continue ARV regimen because renal changes are not likely to be attributed to these drug therapies, or B. Continue current ARV regimen because renal function has not actually worsened, or C. Substitute tenofovir alafenamide for tenofovir disoproxil fumarate because renal function has worsened, or would it be D. Change elvitegravir boosted with cobicistat to a boosted protease inhibitor PI regimen because renal function has worsened? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Continue current ARV regimen because renal function has not actually worsened. The time interval of serum creatinine changes coincides with those of cobicistat, that is, within 4 weeks of initiation. Changes from baseline of less than 0.2 mg per deciliter represent inhibition by cobicistat of tubular secretion of serum creatinine with no change in GFR. That makes answer A incorrect. Therefore, the renal function has not worsened on the current treatment. That makes answer B correct and answer D incorrect. Because the change in serum creatinine did not exceed 0.4 mg per deciliter, renal tubulopathy caused by tenofovir disoproxil fumarate should not be suspected. That makes answer C incorrect. Please advance to the next question. And the next question reads, SKA, is a 45-year-old male patient who presents to the clinic, with a chief complaint of nausea and abdominal tenderness, has been out of care for 1 year. He denies weakness or muscle pain. He has a past medical history significant for gonorrhea, chronic hepatitis B virus HBV, hyperlipidemia, and alcohol abuse. He admits not taking his HIV regimen comprising of darunavir, ritonavir, tenofovir disoproxil fumarate, emtricitabine over the past 4 months. He had been taking this regimen for 3 years. Other medications include rosuvastatin, which he has been taking for 2 years, and ranitidine, which he takes occasionally. His pertinent labs include a viral load 287,000 copies per milliliter and CD4 71 cells per millimeter cubed, which is 7%. His chemistries today are normal, except for increased AST of 78 international units per liter, ALT of 123 international units per liter, and total bilirubin 2.4 mg per deciliter. Transaminase concentrations were within normal limits last year when he was receiving HAART, so, my question to you is, which course of action listed below would be the best for SKA regarding his transaminase elevations? Would it be A. Discontinue rosuvastatin because it may be contributing to LFT elevations, B. Substitute an integrase inhibitor for PIs, because LFTs are elevated, or C. Counsel patient on reducing alcohol, and reinitiate HIV medications after laboratory reevaluation in 1 month, or D. Reinitiate HIV regimen today, and reevaluate LFTs in 1 month. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Reinitiate HIV regimen today, and reevaluate LFTs in 1 month. This patient's viral load reflects non-adherence to ART. He has chronic HBV, and non-adherence to tenofovir and emtricitabine have resulted in a hepatitis flare. Resuming medications will treat HBV, and transaminases should decline. That makes answer D correct. This untreated HBV co-infection with non-adherence to ART is more likely the cause of his transaminase elevations than alcohol. His AST to ALT ratio is not greater than 2 to suggest alcoholic hepatitis. That makes answer C incorrect. He has been prescribed ART and rosuvastatin for at least 2 years, and transaminase concentrations were within normal limits on therapy. Therefore, these medications are not likely causing drug-induced hepatotoxicity. That makes answers B and A incorrect. Treatment should not be delayed in this patient because his CD4 count is less than 100 cells per millimeter cubed. That makes answer C incorrect. Please advance to the next question. And the next question reads, GCS, is a 45-year-old female patient with a diagnosis of disseminated Mycobacterium avium complex infection, abbreviated as MAC. She has been out of care with the clinic for 24 months and admits being off ART for about 1.5 years. Her chief complaint is night sweats and fever for the past 60 days, and she has lost 11.3 kilograms during this period. Her current labs include low hemoglobin, hematocrit, and WBC normal serum creatinine, and increased ALT and alkaline phosphatase. Her viral load is 268,210 copies per milliliter and her CD4 count is 16 cells per millimeter cubed, which is 2%. So my question to you is, which of the following statements best characterizes the clinical presentation of MAC infection in HIV-infected patients like GCS? Is it A. CD4 count less than 50 cells per millimeter cubed, fever, and increased LFTs, or B. C. D4 count less than 50 cells per millimeter cubed, fever, and night sweats, or C. CD4 count less than 200 cells per millimeter cubed, night sweats, and weight loss, or is it D. CD4 count less than 200 cells per millimeter cubed, fever, and anemia? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. C. D4 count less than 50 cells per millimeter cubed, fever, and night sweats. Advanced immunosuppression with a depleted CD4 lymphocyte count is a critical risk factor for disseminated MAC infection. The infection rarely presents in patients with CD4 counts greater than 50 cells per millimeter cubed. That makes answers D and C incorrect. This patient has been off ART for an extended period, resulting in decreasing CD4 counts to less than 50 cells per millimeter cubed. Anemia commonly develops and is severe. Fever, night sweats, and unintentional weight loss are also classic presentations, with the most common of these being fever and night sweats. That makes answer B correct. Increased LFTs are not common but may be slightly elevated. However, alkaline phosphatase concentrations may be significantly increased in 5% of patients, which makes answer A incorrect. Please progress to the next question. And the next question reads, SJT, a 27-year-old male patient presents to the HIV Comprehensive Care Clinic, abbreviated as CCC, today with a chief complaint of headache, nausea, vomiting, and visual changes. 42 days ago, he was discharged with a sterile CSF culture after a 14-day hospitalization for treatment of cryptococcal meningitis. During this hospital admission, he was determined to be HIV positive and was confirmed tuberculosis (TB) negative. 72 hours before discharge, SJT was initiated on highly active antiretroviral therapy, abbreviated as HAART, with darunavir boosted with ritonavir, and tenofovir co-formulated with emtricitabine and referred to the HIV CCC. He has received HAART for 42 days now and reports full adherence to these medications and fluconazole 400 mg daily. Current labs, he is virologically suppressed with an improved CD4 count from 22 cells per millimeter cubed in the hospital to 63 cells per millimeter cubed now. So my question to you is, which of the following statements offers the best explanation for SJT's symptoms? Is it A. timing of ART initiation, or B. underdosing of fluconazole for indication, or C. relapse of cryptococcal meningitis, or is it D. suboptimal fluconazole concentrations with current ART regimen? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. timing of ART initiation. Today, this patient presents with signs and symptoms of cryptococcal meningitis. His CSF culture after antifungal treatment in the hospital was clear, indicating successful induction therapy. Fluconazole therapy at 400 mg is appropriate consolidation therapy for 8 weeks, and the patient indicates he has been adherent. That makes answer B incorrect. In light of successful induction therapy, appropriate consolidation therapy, and adherence to maintenance therapy, relapse is unlikely. That makes answer C incorrect. Antiretroviral therapy was initiated within 2 weeks of antifungal induction therapy. As a result, this patient is at high risk of IRIS, which may be indistinguishable from actual infection on clinical presentation. That makes answer A correct. Presentation typically occurs within 2 months of initiating ART. The CSF must be re-evaluated to confirm IRIS. Regarding drug-drug interactions, this patient's ART regimen would not induce the metabolism of fluconazole, which makes answer D incorrect. Please proceed to the next question. And the next question reads, CSS, is a laboratory technician who reports to her supervisor that she accidentally pricked herself with a needle used for obtaining a patient's blood. The source patient was admitted to your hospital for pneumonia and anemia, and his symptoms include fever, cough for 2 to 3 weeks, weight loss, and lymphadenopathy. The patient's past medical history is significant for hypertension, end-stage renal disease, and syphilis. Which of the following would be the most appropriate course of action in CSS's case regarding post-exposure prophylaxis? Would it be A. Test source patient for HIV RNA, then start post-exposure prophylaxis, abbreviated as PEP, if positive, or B. Perform a rapid HIV test on the source patient, then start PEP, if positive, or C. Source patient does not have HIV, so PEP is not indicated, or would it be D. PEP prophylaxis for 28-day? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Start post-exposure prophylaxis PEP prophylaxis for 28 days. This patient's symptoms are highly suggestive of HIV infection with an opportunistic infection, abbreviated as OI, that is, fever, weight loss, lymphadenopathy, and anemia, as well as a risk factor for HIV infection, that is, syphilis. That makes answer C incorrect. An OI diagnosis in a patient with undiagnosed HIV would indicate advanced infection and typically high viremia, another risk of HIV transmission. As a result, PEP prophylaxis is indicated. That makes answer D correct. Post-exposure prophylaxis should not be delayed in a healthcare worker awaiting the results of an HIV test. That makes answer B incorrect. Rapid HIV testing will yield a result more quickly than HIV RNA testing, which can take several days to a week to report, which makes answer A incorrect. Please advance to the next question. And the next question reads, RPA, is a 26-year-old male patient with a diagnosis of disseminated Mycobacterium avium complex, abbreviated as MAC infection. He has a history of non-adherence, and his regimen was changed to a regimen of tenofovir alafenamide and emtricitabine with darunavir boosted with ritonavir 24 months ago on the basis of resistance testing. RPA has been off his HIV medication for over 12 months. He is starting MAC treatment today, with clarithromycin 500 mg twice daily, ethambutol 1200 mg once daily, and rifabutin 150 mg once daily. So my question to you is, which of the following strategies would be the best for RPA's clinical scenario now? Would it be A. Restart ART in 14 days' time, but change rifabutin to twice-weekly dosing, or B. Restart ART in 2 weeks, but change tenofovir alafenamide to tenofovir disoproxil, or C. Restart his current ART regimen in 14 days' time, or would it be D. Restart his current ART regimen today? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Restart ART in 2 weeks, but change tenofovir alafenamide to tenofovir disoproxil. To minimize the risk of IRIS, ART initiation should be delayed for 2 weeks after treatment for MAC infection. That makes answer D incorrect. Rifabutin induces P-glycoprotein, which may reduce the absorption of tenofovir alafenamide. It is recommended not to co-administer rifabutin with tenofovir alafenamide to prevent treatment failure. That makes answer C incorrect. This interaction does not exist with tenofovir disoproxil. That makes answer B correct. Rifabutin dosing with strong 3A4 inhibitors such as darunavir and ritonavir necessitate reduced rifabutin dosing to 150 mg. More recent data in HIV-treated patients with TB showed lower rifabutin concentrations when dosed 3 times weekly, suggesting inadequate dosage. That makes answer A incorrect. It is now recommended to dose PEs with rifabutin daily and monitor for rifabutin adverse effects such as neutropenia and uveitis. Please proceed to the next question. And the next question reads, PSP, a 53-year-old female patient is admitted to the hospital for the treatment of cellulitis on her left leg. She has a past medical history significant for type 2 diabetes mellitus, hypertension, and trichomoniasis. Her chemistries on admission show normal except for glucose 297 mg per deciliter, serum creatinine 1.3 mg per deciliter, and total bilirubin 4.2 mg per deciliter. On doing medication reconciliation, it is established that PSP has been taking ritonavir, atazanavir, and abacavir plus lamivudine since her HIV diagnosis 8 years ago. Her other medications include lisinopril, amlodipine, metformin, insulin, and atorvastatin. She is not jaundiced and denies complaints other than her leg infection. So my question to you is, which of the following is the best assessment and ARV plan for PSP? Is it A. Hyperbilirubinemia is related to atazanavir and should be substituted with alternative therapy, or B. Hyperbilirubinemia is related to atazanavir, and the dose should be reduced, or C. Hyperbilirubinemia and renal changes are related to her PEs, therapy should be changed, or is it D. Patient is asymptomatic without jaundice, therapy should be continued? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Patient is asymptomatic without jaundice, therapy should be continued. This patient presents with asymptomatic hyperbilirubinemia. Atazanavir inhibits the conjugation of bilirubin by inhibiting UGT, increasing total bilirubin concentrations in most treated patients. Studies have shown no safety concerns in continuing therapy in asymptomatic patients with elevations less than 5 times the upper limit of normal. That makes answer D correct, and answer A incorrect. As a result, the dose should not be reduced. That makes answer B incorrect. Hyperbilirubinemia is reversible on discontinuation of atazanavir. Patients have developed renal insufficiency while receiving boosted atazanavir regimens. However, advanced diabetes and hypertension may be greater risk factors in this patient, which makes answer C incorrect. Please advance to the next question. And the next question reads, TMW, a 46-year-old female HIV-positive patient, is diagnosed with cryptococcal meningitis. She isn't on highly active antiretroviral therapy, and she begins antifungal therapy for cryptococcal infection. On the third day of treatment, a repeat lumbar puncture reveals an increased CSF opening pressure. The CSF is drained, and her fever and headaches have improved over 10 days of amphotericin B and flucytosine. Today, her headaches have recurred with vomiting and visual deterioration in her right eye. A lumbar puncture is done, and her CSF opening pressure has increased. So my question to you is, which of the following would be the best approach to improving TMW's symptoms? Would it be A. Repeat CSF culture and change to high-dose fluconazole if positive, or B. Repeat CSF culture and increase the dose of amphotericin B if positive, or C. Do a lumbar puncture for CSF drainage, or would it be D. Add dexamethasone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Do a lumbar puncture for CSF drainage. In the CryptoDex study, dexamethasone given during the first 2 weeks of cryptococcal meningitis treatment did not reduce mortality and resulted in slower CSF fungal decline. Compared with placebo, the dexamethasone arm had more adverse effects, including infections, electrolyte disturbances, and cardiac, renal, and GI disorders. As a result, dexamethasone is not recommended in cryptococcal meningitis except in the IRIS scenarios. That makes answer D incorrect. It is customary to withdraw CSF fluid to reduce intracranial pressure during induction therapy. That makes answer C correct. Amphotericin B and flucytosine have excellent efficacy, and higher doses are generally unnecessary. That makes answer B incorrect. Therapy may be extended beyond 2 weeks if signs and symptoms are improving but persist after 2 weeks of therapy. Fluconazole is less efficacious than amphotericin B and flucytosine. That makes answer A incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 166.